We are live.
A very good evening, everyone. Welcome to AI's GuruSangam 2025-2026 edition, where we educate, elevate, and excel. And this is the session 12 on UVEA, and we welcome you all. We thank the AI's dignitaries and Dr. Aditya, can you move this on? Yeah, we thank the AI's dignitaries, Dr. Pasa Biswas, sir, the President, Dr. Santosh Nava, sir, the Honorary General Secretary, Dr. Manoj Mathur, sir, the Honorary Treasurer, and we also invite our speakers for the day, Dr. Jyotirmay Biswas, sir, Shankar Netralaya, Chennai, Dr. Patu Pratim Datta Majumdar, sir, from Shankar Netralaya, Chennai, and Dr. Arshi Ahmed, ma'am, sir, from Shankar Netralaya, Chennai. So it's like a SN Chennai session today. And we also have our expert panelists, Dr. Balamurgan Esther from Arvind Eye Hospital, Pondicherry, Dr. Kalpana Murthy ma'am from Prabha Eye Clinic, Bangalore, Dr. Reema Bansal ma'am from Advanced Eye Care, PGI, Chandigarh, Dr. Soumya Basu sir from LVPI, Hyderabad.
We have very interesting talks lined up today. Dr. Partho will be speaking on therapeutic immunosuppression in uveitis, principles, practice, and pitfalls. Dr. JB sir will be speaking on PCR in ocular infection and inflammation. Dr. Arshi Ahmed ma'am will be speaking on complications in uveitis. Today's session will be moderated by Dr. Rolika Bansal from Mahatma Gandhi Medical College, Jaipur, and myself, Dr. Aditya Patil from Ojas Maxivision Eye Hospital, Mumbai. So I would like to...
Over to you. Yeah. Over to you, Jyotirmay Biswas, sir, for your talk. So please share your screen, sir. The audience is requested to please share your questions on the portal so that we can take it to the speakers. And please feel free to put any comments and we'll address that in the lectures as well.
Yes, yes.
Please take your time, sir, no problem. Yeah.
Yeah. Is it seen?
Yes, sir. Thank you so much. Please proceed, sir.
Good evening. At the outset, I'd like to thank AIOC and my moderators and panelists, as well as today is a great opportunity for me to talk on polymerase chain reaction in ocular infection and inflammation. I've been working for last 40 years. I'm presenting from Chitrakoot from MP. Longness is a new place, so I was a little bit nervous that my slide will come or not. Now I'm quite okay. My slides are there. So I'll be talking on polymerase chain reaction in ocular infection. I'll be showing some examples and a little bit about polymerase chain reaction. I dedicate this oration to my beloved Chief Padma Bhushan, Dr. S.S. Badrinath, who was my mentor. And 2 years back, he passed away. Why I'm dedicating is that our polymerase chain reaction started with his vision and influence. He saw that this technique is adopted by our unit, by Professor Madhavan, our institute. And from there, we have very early stage in 1990s, we started doing the polymerase chain reaction in ocular infection and inflammation. Polymerase chain reaction is a kind of a DNA technology, and it involves a machine. And Carey Mullis, 1983, he wrote this paper, landmark paper, primer-directed enzymatic amplification of DNA with a thermostable DNA polymer. this thermostable DNA polymer made a kind of a great change in the scenario of detection of ocular detection of infections, or in fact in the medical sciences. And all branches of medicine today has adopted this technique, polymerase chain reaction. And 1993 rightly awarded the Nobel laureate in chemistry for his invention in the polymerase chain reaction method. This is a picture of getting his Nobel Prize. So PCR amplifies one segment of the DNA in a complex mixture. So at least some of the DNA sequence on either side of the region to be assayed should be known. That is called primers. It's some kind of very simplified way. It's a xeroxing of the DNA segment. It's not that simple, but I'll come to that. And PCR technique, I just took the help of a animation slides, and I'll show you.
PCR depends on a series of 20 to 40 repeated cycles of DNA replication by a DNA polymerase enzyme. After each cycle, the number of DNA strands is doubled, and at the end of a 40-cycle reaction, more than 1 trillion copies are generated from a single copy of a DNA molecule. The PCR process is separated into 4 steps: initialization, denaturation, annealing, and elongation. In the first initialization step, the reaction is heated to 94 to 96 degrees Celsius for 2 to 10 minutes to activate the DNA polymerase and to denature other contaminants in the mixture. In the case of colony PCR screening, this step also facilitates cell lysis to release DNA and denature other cellular proteins. In the denaturation step, hydrogen bonds between the double-stranded DNA are broken by heating the reaction to 94 to 98 degrees Celsius for 20 to 30 seconds. After the DNA strands are separated, primers bind to a complementary sequence in the DNA template to guide DNA polymerase replication. In this step, the reaction temperature is lowered to 50 to 65 degrees Celsius for 20 to 40 seconds to allow for optimal primer annealing. After the primers establish a starting point for the enzyme, DNA polymerase starts to incorporate deoxynucleotide triphosphates in a 5' to 3' direction to synthesize a new DNA strand. The temperature and extension time for this elongation step depends on the type of DNA polymerase enzyme and the target amplicon. Commonly used Taq polymerase polymerizes at a speed of 1 to 1.5 kilobases per minute and works ideally at 72 to 78 degrees Celsius. The cycle then repeats from denaturation to elongation 20 to 40 times. At the end of the last cycle, there is a final elongation step that keeps the reaction mixture at 72 to 78 degrees Celsius for 5 to 15 minutes. This ensures that any remaining single-stranded DNA is fully extended after the last PCR cycle. A final holding step keeps the PCR at 4 to 15 degrees Celsius for an indefinite time, keeping the products for short-term storage. The most common DNA polymerase enzyme used in PCR is Taq polymerase, a thermostable DNA polymerase that allows multiple cycles of amplification without the addition of new enzyme after each denaturation step. Since the initial discovery of Taq DNA polymerase, many variations of the Taq enzyme have been engineered with different attributes that can be utilized for specific PCR applications.
So it was a kind of a DNA technology, and what is remarkable is that it has got a tremendous ease and sensitivity and the speed which stands apart from other biochemical techniques. This is a PCR machine which you can see is not very costly and is a gel amplification system, agar gel amplification system, and this is a gel documentation system over here. What is interesting in that one, what is the basis of the PCR? They have got inbuilt positive control and negative control. So positive control should be positive control, positive, showing the high degree of sensitivity, and negative control would be negative, should be showing that high degree of specificity. And there is a molecular weight marker which tells us that what level is this primers is amplified. So samples are put over there and it is compared with the molecular weight marker. Real-time PCR is a different. Very simply, it can be called as a technique that used to monitor the progress of the PCR reaction in real time. Here is the difference is that the fluorescent molecule is used to monitor the PCR reaction. The fluorescence emitted by the fluorescent molecule manifolds as the PCR product accumulates with each cycle of amplification. And this is the real-time PCR machine, is a small machine. And here is the green arrow is showing that the sample, red arrow is showing the standard curve. And this is the way it is compared in case of real-time PCR. Where is the PCR is used is inflammatory disease of the eye or infective disease of the eye. Diagnosis of infections, uveitis, scleritis, keratitis, endophthalmitis, particularly when the pathogen is difficult to culture like virus, viral retinitis, granulomatous uveitis. We have done a lot of work on yeast disease in the research on PCR, find out the etiology, and the toxoplasmosis, other things like toxocara. What are the infectious agents by detected by PCR? Mycobacterium tuberculosis, E. bacterial genome, Propionibacterium acnes, E. fungal genome, Toxoplasma gondii, Leptospira, chikungunya, and host of viruses like HIV, CMV, HSV, HBV, VZV, EBV, rubella, and every day many new pathogens are added in the array. So where from we can take specimens? You can take specimens from anywhere from the eye, from the surface of the cornea, like HSV keratitis, or from the anterior chamber in anterior uveitis, from the conjunctiva you can take in conjunctivitis, the vitreous, then subretinal fluid. Even you forgot to take the fluid and material, you have made a slide, you can scrape the slide and the given DNA from the paraffin section can be used. I'm going step by step or segment by segment how we have used PCR. Anterior uveitis, suspected tubercular anterior uveitis, suspected viral anterior uveitis. So this is a PG class. I'm making it a very simple one. So way back in 27 years back, we did that. Maybe we are the first person to do that PCR reactions in the uveitis, 1988, which was published in the proceedings. The use of polymerase chain reaction in the detection of Mycobacterium tuberculosis complex DNA from the aqueous sample of suspected tubercular uveitis. We used 18 cases and 4 of them were positive by nested PCR for Mycobacterium tuberculosis. This is a very old 1998 photograph, a granulomatous uveitis, and there are a sample of 4 cases which was found to be positive. Now he is showing a classic case of a PCR positive anterior uveitis. This is a 21-year-old female with granulomatous anterior uveitis, mutton fat KPs, broad posterior and peripheral anterior synechiae. All this indicates suspicion of tubercular uveitis, and based on that we did an AC tap, and AC tap showed Mycobacterium tuberculosis by nested PCR, MPB64 and IS6110 region positive, 200 base pair. So we did a study and which was published in 2025 on ocular immunogen inflammation in granulomatous anterior uveitis, 51 eyes, 65.8%, we found Mycobacterium tuberculosis DNA by PCR. Tubercular uveitis can be presented as a pigmented hyperplasia. It's a very unusual and atypical case. And this patient has got a convex pigmented hyperplasia, and PCR was done, and PCR was positive for Mycobacterium tuberculosis DNA. This is a 59-year-old lady, is a chronic uveitis with pigmented KP. Intraocular pressure was 42 millimeter of mercury. It was suspected to be tubercular uveitis. but we suspected viral in uveitis, and we did an AC tap. Real-time PCR for herpes simplex virus type 1 was positive, indicating that this is a viral anti-uveitis and patient responded to the treatment. And here I will show you a real-time polymerase chain reaction in a recurrent cytomegalovirus anti-uveitis, which was published in 2019 in American Journal of Ophthalmology case report. And this patient presented with the large kerattic precipitate in the central cornea in the left at the first visit. And then PCR was positive for CMV, treated, patient responded, PCR was negative, again recurrent, and then we did a PCR again, PCR was again positive. I'll show you step by step, and this is a test sample, and this is the beginning of the presentation, and the kerattic precipitates, and that test sample is the green arrow is showing positive. And when the patient was treated with antiviral drugs and responded well, the patient used to come from Oman actually, and this almost every 2 weeks used to come, and the test sample was found to be negative. The patient had a recurrence after 6 months, and then when he did that PCR, real-time PCR, it showed copies of the copies of the herpes cytomegalovirus DNA. This is a case of a moth-eaten iris in PCR positive herpes simplex. It was diagnosed as a Fuchs uveitis. We did an AC tap, and AC tap on real-time PCR was found to be positive for herpes simplex type 1. Intermediate uveitis, the polymerase chain reaction confirmed mycobacterium tuberculosis in 14 cases, 22 eyes. And this is one of the cases with broad posterior synechia, and there is a vitreous exudates were there in that vitreous. Left eye, the vitreous haze was, right eye, the vitreous was dense. We did that vitreous biopsy, and the vitreous biopsy in real-time PCR showed both nested and real-time PCR both showed mycobacterium tuberculosis DNA. And this is actually a very interesting case. Is the tubercular uveitis, which has got dense vitreous opacity in one eye and vitreous exudates in the other eye. We did the vitrectomy in the right eye, and vitrectomy we could find out a granuloma. That exactly tubercular granuloma which you see, we found a granuloma with the histiocytes and liver epithelial cells, the macrophages, etc. And this granuloma, when we did the PCR study, nested PCR for MPV64 and IS6110 region was positive. Coming to the posterior uveitis, this is a case of a 34-year-old man, dramatic loss of vision, peripheral necrotizing retinitis with scalloped margin. Clinically, we suspected viral anti-uveitis, but we need to know which virus it is, and we need to confirm it. We did a AC tap for PCR for herpes simplex type 1, type 2, and herpes zoster virus and cytomegalovirus. Herpes zoster virus was positive, 100 base pair. And the patient, based on that one, treated with the intravenous and oral valsaclovir along with the intravitreal ganciclovir, and showed a significant response, complete clearing of the retinitis lesion. And this is a case of a progressive outer retinal necrosis, and here we did the agrosgel erythropoietin from the aqueous and vitreous samples, which was found to be positive for cytomegalovirus. And this was published in Indian Journal of Ophthalmology. And this is a patient, very interesting. This patient is having progressive outer retinal necrosis, a very severe retinal necrosis, along with a abdomen, a herpes zoster lesion. We did PCR from the varicose zoster virus, and it showed positive reactions. And real-time PCR showed 6 crore 83 lakh 20,000 copies of the varicose zoster virus DNA. And we tried to look into the viral retinitis and acute retinal necrosis, that amount of inflammation, the quadrant of involvement, along with the real-time copy number, And we found the copy number correlates with the extent of the viral infection. If it is a 3 or more quadrant is involved, viral copy number is high than 1 quadrant involved when the viral copy number is relatively low. And this is a 66-year-old lady, history of fever, my old man, history of fever for 1 week, diminution of vision, and he had got a multiple posterior pole exudate. And this was, we are suspecting chikungunya. In fact, chikungunya, we ruled out also other viruses, and chikungunya virus was positive, showing 416 copies of the chikungunya virus DNA. And the patient responded to the treatment. In case of, there's a very interesting thing is that we can find out in the HIV itself can produce uveitis. We did real-time polymerase chain reaction for HIV. We ruled out other viruses and found out the HIV is the sole cause of uveitis in 3 cases. And we had a series of choroiditis cases which has got spillover anterior uveitis, and we took the anterior chamber tap and we did the PCR study, nested PCR study, and that was found to be positive and which was helpful in the diagnosis. This got the Nursing Rao base paper out way back. This is a 19-year-old girl, example of that case is from Uttar Pradesh. We have taken a fluid tap, fine needle aspiration biopsy from the mass lesion, the abscess, and this was positive for mycobacterium tuberculosis. And the patient, what happened to the patient after 6 weeks of treatment, there was a complete resolution of inflammation after anti-TB treatment. This is a case of 33-year-old patient, active amphigenous choroiditis. And what is the cause? This one, we did the AC tap for PCR for mycobacterium tuberculosis and also other organisms. MPV64 genome for MTB was positive. And this is a nested PCR positive for tubercular amphigenous choroiditis. First time we have reported in ocular immunogen inflammation. Multifocal serpiginate choroiditis, nowadays we call it as a tubercular etiology. Most of us, we don't do PCR for that one. But I did a PCR from the first time. A patient had a anterior chamber inflammation, anterior uveitis. I took aqueous aspirate and then was positive for IS6110. This was published in Journal of Ophthalmic Infection and Inflammation and Infection. This patient presented pictures suggestive of something like I suspecting I couldn't rule out viral retinitis because the peripheral retinitis was there. Though it looks like a choroiditis, I was not very sure. I did a PCR and found that this is positive for tuberculosis, indicating that it is a peripheral serpiginate choroiditis, not a retinal necrosis, acute viral retinitis or acute retinal necrosis. This is a patient of miliary tuberculosis. This patient incidentally have endogenous endophthalmitis in other eye, and we took the opportunity to take the fluid from the other eye, which has got endogenous endophthalmitis, indicating that there is positive for mycobacterium tuberculosis DNA, so that confirming that miliary tubercle of the choroid is itself is due to the tubercular origin. In case of toxoplasmosis, we are not very successful with the PCR, 33% positivity. But when we added with that Coleman-Whitmer coefficient, it was found to be much more specific, much more sensitive for toxoplasma infection. And is a case of a diffuse toxoplasmic retinochoroiditis, is the initial manifestation of AIDS. This patient, initially we thought that is a viral retinitis. We did that vitreous biopsy, and vitreous biopsy as well as the aqueous aspirate did for viruses. But incidentally, we took the toxoplasma also, and the toxoplasma came positive, and the patient was treated with the anti-toxoplasma treatment and was responded very well, shown in the picture on your right side. This is a new case just recently we have seen, and this patient once was diagnosed outside as the toxoplasma. PCR was done as PCR positive, and we did that PCR for all the viruses. I am suspecting that is a CMV retinitis. And I did the PCR, and PCR came for toxoplasma, indicating that the previous institute's diagnosis was correct. Patient was not responding. I did again a PCR study for the aqueous aspirate, and it came positive. So indicating that it is a toxoplasma. Patient ultimately responded to the treatment. So we can rely on the PCR project test for making a diagnosis. This is a case of toxocara. There was a lesions over the optic nerve. There's a membranous lesion. There's a vitritis. There's a little aqueous inflammation was there. And this one a case we did that PCR for toxocara with the help of veterinary department. And veterinary department, they do have the primer for the toxocara and respond to a positive as published. Coming to the pan-uveitis, in 3 cases of tubercular pan-uveitis, Mycobacterium tuberculosis DNA was detected by the nested and real-time polymerase chain reaction. Acid-fast bacilli was seen within the retinal pigment epithelial cells in only 1 case of TB pan-uveitis. And this is one of the case, 25-year-old male, dimness of vision for 6 months. Month 2 was positive. HSCT test was within normal limit. In spite of ATT and oral steroid, lost vision. Occlusive pupil and rubeosis iris, eye became painful and blind eye. Enucleation was done, and enucleated globe we saw caseation necrosis. And that itself was suggestive of tubercular infection. We couldn't find out acid-fast bacilli, but PCR was positive for MPB64 and IS6110, indeed showing that this is a tubercular pan-uveitis, but the patient lost vision already. Retinal vasculitis, I have told briefly about it. This is the most common retinal vasculitis. There was several thoughts about the etiology of this vasculitis, and this is a blinding disease in Indian subcontinent. Retinal vasculitis leading to the vitreous hemorrhage, tractional retinal detachment, etc. So we try to find out that is the East disease due to the tuberculosis? How to prove it? The East disease patients undergo vitrectomy. We took the opportunity to take the vitreous samples and do the PCR study, and 5 out of the 12 samples was positive for MTB DNA, and indicating that it's a tubercular infection in the vitreous cavity. Not only that, epiretinal membrane, when doing the vitreoretinal surgery, 7.8% of the epiretinal membrane was positive for Mycobacterium tuberculosis DNA. Difference was statistically significant. And this is a jail photograph of this series of cases which is found to be positive. We had ultimately found an eye, which is a patient with a painful blind eye. I requested the patient, this is aesthetically was not good. The sunken eyeball of a East disease patient, we did a histopathologic study, and it showed that vascular channels surrounded by the lymphocytes, and CD8 cells was positive, CD3 was positive, CD20 was negative, and then we did the nested and real-time PCR from the paraffin section, and it was found to be positive for Mycobacterium tuberculosis DNA. So we concluded the cell-mediated immunological reaction triggered by sequestered Mycobacterium tuberculosis antigen causes East disease. Coming to the scleritis, this is a patient which have got burnt finger. This is a patient of rheumatoid arthritis which has got nodules, multiple scleral nodules. I treated the steroids, then immunosuppressive agents, ibimethal prednisolone, IV cyclophosphamide, did not respond. The patient lost follow-up for 2 months. When he came with the pus points and the perforated globe, as well as a painful blind eye. So I was surprised, and when I did have the eyeball pathological study done, I was surprised to see the giant cells within the scleral tissue and chronic granulomatous inflammation, indicating that this is not due to the rheumatoid arthritis. This is a giant cell reaction, and PCR was positive for Mycobacterium tuberculosis DNA. So we published this one in Ocular Immunology and Inflammation. We had another case of tubercular sclerouveitis masquerading as ocular tumor, and eye was enucleated. The enucleated globe showed lymphocytic infiltration and PCR was positive for IS6110 for mycobacterium tuberculosis, showing that even tuberculosis can present as a kind of a scleral tumor. We have studied the real-time PCR reaction of 100 suspected cases of infectious uveitis, and our positivity rate was 70%. Few final words about PCR. From the aqueous, we require about 50 microliter sample only, minimal. Vitreous, 100 to 150 microliter. Power and limits of the PCR, 10 to 100 genomes of the viral DNA can be detected. Pitfalls of the PCR, extreme high sensitivity can lead to false positivity. So there is a contamination can possible, laboratory contamination. Rigorous negative control with each PCR reaction has to be done. Match between the primer sequence and the host DNA needs to be near perfect. Negative and positive control samples must be tested with each diagnostic PCR. All PCR diagnostic results should be considered in clinical context. I have got burnt finger that patients have toxoplasmic uveitis presented PCR was positive with TB because there was a granulomatous uveitis. I did the IC-TAP for PCR for TB, it came positive. What's the new in the molecular biologic study of ocular specimens? A new era, we have got multiplex PCR, and I have told is real-time PCR. Instead of using the multiple sample and multiple primer sets, we can use that single tube, and the primers is put into that one, and several samples can put into the one time itself we can run. They establish a multiplex solid phase strip PCR test for detection of 24 ocular infection disease pathogenesis at the same time. This came from Japan. And this is the series of the PCR tests done, and Candida was found to be positive. And the PGI is doing a great work, and that one is, this recent work from PGI is come from the 2025 evaluation of the mycobacterium tuberculosis derived cell-free DNA-based multi-targeted real-time PCR from the vitreous fluid sample to diagnose ocular tuberculosis. And this has found to be the highest detection rate, 76% for the ocular TB compared to the TrueNut and GeneXpert Ultra with 100% specificity. So metagenomic deep sequencing is a new venture, new horizon, which can detect DNA and RNA pathogens from single pathogens in one test. And I'm glad that in the various parts of the country, this test has started, and for the diagnosis of intraocular infection. Illuminating uveitis metagenomic deep sequencing, identifying common and rare pathogens. And we have, there's a publications in way back in 15 years back, identification of new pathogens in the intraocular fluid in patients with uveitis. So it might be that what we are calling as a idiopathic uveitis may be due to some kind of a unknown organisms or relatively new organisms can be possible. So there is a new opportunity of diagnosis of infectious etiology and various ocular inflammation and infection. So this is the last slide. Early microbiology depends on the smear and culture, and the newer technology is a computer-based genetic, computer-based DNA technology, which we are now adopting it. So things are changing, and we must keep running to stay in the same place. PCR is today possible. Next generation sequencing will be coming in soon, and must be in each lab. We can identify not only the organism but also the strain of the organisms also, and almost all the organisms can be identified by molecular technique. Dr. Professor Madhavan, I owe this work most of the works is done by Professor Madhavan, who is the director of the retired director of the our ocular microbiology and molecular biology department. He's retired, but he is still inspiring us. Thank you very much. We continue the legacy, life and legacy of Dr. S.S. Badrinath. Thank you.
Thank you so much, Dr. JB sir, for your very comprehensive and insightful presentation. And I'm sure we got to learn a lot. It is like an encyclopedia of PCR and uveitis.
Sure.
So I would like to ask some questions to our panelists.
Sure.
So Firstly, now when we talk about PCR and uveitis, we know it's a precious sample because it's an intraocular fluid and it's an invasive test. So one of the questions I have is, what would be the best time to do PCR in cases of viral uveitis? Maybe Dr. Kalpana ma'am could take this question.
Ideally, we would, first of all, Dr. JB's talk was so impressive. I mean, even after so many years, it's so nice to sit and listen to everything what Sir said. Coming to your question, I normally would like to tap when the pressures are very high. And the chances, the yield is much higher. And as we all know, PCR in viral uveitis has a very good, very high sensitivity. And especially if you kind of tap these eyes when the pressures are very high, the chances of yield is very good. This is especially so for cytomegalovirus
Yes.
suspected anterior uveitis. When we look at HSV and VZV, there's a nice paper by Aniki Rutova's group actually, which they did look at the factors which influence the yield or PCR positivity in these eyes. And two factors which, apart from increased intraocular pressure, the time of the tap, is presence of pigmented keratic precipitates when you see them on the corneal endothelium and iris atrophic patches. The chances of your yield with the other two viruses are also very high, HSV and VZV. But the most important thing is, I think it's best to tap them when the pressures are very high.
And ma'am, what about cases where we have posterior viral uveitis, like viral retinitis? What would be the best sample in such cases? Would it be aqueous or vitreous?
So aqueous for logical reasons, because it's easier to tap these eyes, and especially with HSV and VZV, we are always worried to enter the vitreous. But the thing about the PCR, I'm sure Dr. JB also will agree, it has a very high sensitivity and specificity for HSV and VZV, and these
Yes.
are two important viruses which we are looking at when we are looking at the retinitis per se. So in my practice, aqueous has worked very well in these eyes as well. And if you're not able to, and then of course the vitreous biopsy, but ideally this.
I think I'll do that aqueous first.
Yeah.
Aqueous first, sure. I have one more question for Dr. Basu. So could you share your experience with PCR in tubercular uveitis, like especially? Dr. JB sir mentioned close to a 63% or 68% yield.
68%.
68%, yeah. So, sir, your experience?
Yeah, thank you, Aditya. I'm sorry I'm in a car, so you might get some background noise. The role of PCR in tubercular uveitis is very exciting because, that is probably the only place where you can get a direct evidence of mycobacterial infection from the eye. At the same time, it should be taken with a bit of a pinch of salt because in TB endemic countries, it is common to have the mycobacterial DNA within the monocytes that are in the circulation. Now, whenever there is an inflammation or there is an accumulation of monocytes at any place, the mycobacterial DNA can land up in that place. We did a study very long ago where we looked at, I think, about 60 cases of culture proven post-operative endophthalmitis, completely unequivocal cases. And in those, we tested for Mycobacterium tuberculosis PCR, and 16% of those endophthalmitis samples turned out to be TB PCR positive. Dr. Rima Bansal, who is here today, she has a publication where subretinal fluids of patients undergoing retinal detachment surgery was taken. And even there, the subretinal fluid of some of the patients was TB PCR positive. So we should be very cautious in interpreting a negative PCR test as well as a positive PCR test. In the current scenario, I think the diagnosis of tubercular uveitis remains clinical based on the different guidelines that are available. Only in the atypical cases, you would want to look for PCR and then apply whichever conventional or real-time PCR or some of the techniques, more recent techniques like Gene Expert or Line Probe assay to get a molecular verification of the diagnosis.
So we should be wary about false positive TB PCR in these cases.
Yeah, absolutely. And this same rule applies to cytomegalovirus as well, not to HSV or VZV, but to CMV, because that is another virus that lives
Ubiquitous.
within the monocytes. So if when you get a CMV positive PCR, you have to be sure that uh, you have to do a real-time PCR first of all, and make sure that your cutoff of the number of copies of CMV virus is beyond a certain point. Only then you would consider it true CMV PCR positive. So the same rule would apply there as well. Just a quick point on your, what stage of infection would you want to do the PCR? It's always better to do early in the course of the infection, and this has been shown very elegantly in Toxoplasma retinochoroiditis, where in the early stages of infection, PCR is usually positive, whereas in the late stages, it is the Goldman-Whitmer which is more useful. Of course, we don't do it in India, but technically that is how the diagnostic should be approached.
Sure, sir.
Aditi,
Thank
can I
you.
just add one point to what Somavia said? Actually, this thing of early on in the course also is very useful for HSV related uveitis as well. If you tap these eyes much later in the course, usually many times they are negative, the herpes simplex related uveitis. So I think that's very, very important if you can do it in the early stage.
Sometimes we see these cases with chronic anterior uveitis, which have iris atrophy, which have pigmented old KPs with chronic glaucoma, and phenotypically it looks like viral uveitis. But doing a PCR is like taking a chance, because we don't have IOP spikes, we don't have acute inflammation, so the yield is also doubtful. So that's why I had that question. So, okay, so I think I would like to invite Dr. Partho sir for his talk.
Thank you.
Thank you, Dr. JV sir. Yeah, your slides are seen, sir.
Yeah. So good evening, all. Can you hear me?
Yes, sir, we can hear you.
Good evening, all. My sincere thanks to AIVS for selecting my topic and allowing me to speak on a topic in a program which is designed for the postgraduates. I keep my talk a little more of theoretical, oriented for understanding the basics and practice and principle of immunopharmacotherapy, which we use in uveitis.
You can go.
Today we'll be talking about the medications which are used to intentionally reduce the immune system activity, preventing it from attacking healthy tissues in autoimmune diseases, rejecting in transplants, or causing excessive inflammation. So here in this talk, we'll be discussing primarily the therapeutic immunosuppression specific to the treatment of uveitis. So, immunosuppressive therapy primarily targets T cells, but in reality, it can modulate almost every major immune compartment like T cells, B cells, antigen-presenting cells, and even elements of innate immunity. So that all depends on the drug class and the disease context. Among these, the CD4 affected T cells remain the primary target of most conventional agents, including corticosteroids, calcineurin inhibitors, antimetabolites, and also the JAK inhibitors. So these drugs reduce the cytokine production, T cell proliferation, and helper T cell signals to the B cells. Now, we'll be discussing the drugs that help in immunosuppressions. This talk has been designed specifically for postgraduates, as I told. So I have tried to include simplified diagrams, keeping the postgraduate learning what the postgraduates needs in mind, and have tried to simplify some mechanism of action. So I have also included the corticosteroid as they remain the cornerstone of the immunosuppression and anti-inflammatory therapy. Although it is not possible to include all the clinical trials related to that, I have tried to touch few important trials which the postgraduates need to know to more about the relevance of this kind of therapies. Now, coming to the mechanism of action, if you look at the various drugs, I'll start with the corticosteroid, but you will understand the more immunology better when we will be discussing the biological therapy. Now, corticosteroid, if you see broadly what it does, in contrast to antimetabolites or immunosuppressives or biologicals, they try to redistribute the lymphocytes, especially the T lymphocytes, from the intravascular space to the extravascular tissues such as bone marrow, spleen, lymph node. Now, if you go into the details, there are a lot of mechanism of action of this corticosteroid. I am not going into details because you have to read about it and you have to learn about that, like how corticosteroid inhibit the activation of the T lymphocyte, inhibit the migration of the neutrophil. But basic mechanism is that they shift the T lymphocyte from intravascular space to the extravascular space. Now, then comes, we have something called antimetabolites, like we have the methotrexate, you have mycophenolate and azathioprine. So what they do, they works by tricking the cells into using fake version of the important molecules that our cells require to synthesize the DNA and RNA. So because of this tricking by this drug, this disrupts the cell's metabolism and stop them from growing. So that's why they are called antimetabolites. Now, the next group is anti-alkylating agents. Now, in this alkylating agents, they damage the DNA directly by attaching the alkyl groups to it. So this injury prevents the cells from dividing and eventually leads to the cell death, especially the first growing when the immune cells are under stimulation and trying to replicate, grow faster. Than in that case, this alkylating agents hits in a hard way. Our next group is the T cell inhibitors. So what they do, they block the calcineurin. Now, what is calcineurin? Calcineurin is an enzyme necessary for T cell activation. Now, without calcineurin, what will happen? The interleukin 2, which is a growth signal for the T cells, cannot be produced. So the T cell fail to multiply or become fully active. Now we'll go into the most interesting part of the mechanism of action of biological agents, which will give you some perspective about the immune system, what actually plays a role in inflammation. Now, if you see the inflammatory cascade in uveitis, so it begins with when an antigen presenting cells encounters an antigen and process it for immune recognition. Now, this antigen presenting cell then presents to the antigen to a naive T cells, which is resting. So this delivering the both antigen specific signal and which we call the co-stimulation, this co-stimulatory cues needed for this activation of such a naive T cells. Now, B cell also sometimes can actually contribute here. After binding to an antigen through their B cell receptor, they function as additional antigen presenting cells, further reinforcing early T cell activation. Now we'll see there are two classes of biological agents which acts here. The number one is the rituximab. This depletes the CD20 positive B cells, thereby reducing the B cell mediated antigen presentation. So that's the mechanism of action of rituximab. Now this co-stimulatory effect or cues are prevented by the abatacepts, which blocks the CD80 and 86 and prevents this co-stimulation of the naive T cell by the antigen presenting cells. So that's how these two attack. Now we'll go into the further mechanism of action. So now what will happen? The T cell, once it is activated, they will start replicating and differentiating. Now this mechanism is primarily driven by the interleukin 2 signaling. Correct. So in this stage, there is another class of biological agents. Popular, you must have heard the name, the daclizumab. So this daclizumab blocks the interleukin-2 mediated T cell proliferation, and they prevent this clonal expansion of this. Now, what will happen? Now, this clonal expansion is expanded. So the T cell, they differentiate into inflammatory subsets. Now, what are the subsets? Some become Th1 cells, which produce the interferon gamma and activates the macrophages. And other group of T cells, they differentiate into Th17 cells. They will produce interleukin 17 and they will drive the neutrophilic inflammation. Now, in this stage, you have to understand that this Th1 and Th17 population of T cells represents the true uveatogenic pathogenic T cells, which is central to a ocular inflammation. So, cytokines such as interleukin 1 and interleukin 6 stabilize and amplify this pathway. So these two interleukins are very important here, which play a role in this generation of these uveatogenic T cells. Now, here we have two important class of biologicals. One is tocilizumab, which is a interleukin-6 receptor inhibitor, and we have anakinra, which is interleukin-1 receptor antagonist. Clear? So now what we'll see, as this Th1 and T7 cells mature, they release a broad array of pro-inflammatory cytokines. There's a numerous cytokines are there, but we can name a few very important like interleukin-2, interleukin-6, interleukin-1, TNF-alpha, and interleukin-17. Now, these cytokines recruit and activate the additional inflammatory cells, creating a powerful amplification loop. Now, when the cytokines are already playing and triggering the pathways of inflammation, then we have some agents which acts on these cytokines. Like we have TNF-alpha inhibitors like infliximab, adalimumab, which inhibit this TNF-alpha cytokines. We have interleukin-17 inhibitors like secukinib. We have interleukin-6, we have already told, the tocilizumab, interleukin-1 like anakinra, and interleukin-2 inhibitors like daclizumab. Now, one thing I must tell you that daclizumab is withdrawn from the market because of the severe inflammatory brain disorders, like they cause the encephalitis. Now we have another agent which is interleukin-2 inhibitors, that is known as basiliximab. So we'll quickly go to the last class of drug. It is that before going to that, I just telling something like think the cytokine as a messengers that instruct the immune cells to generate inflammation. So they in such a way they deliver this message and they rely on internal pathway which acts as a switch turning the inflammation whenever they are activated. Now this pathway is called JAK-STAT pathway. And this pathway is inhibited by a class of drug called JAK inhibitors, which includes tofacitinib, udanocertinib, and baricitinib. Now, coming to that immune suppression of uveitis, one must remember that the immune suppression remains the cornerstone of managing the sight-threatening intraocular inflammation. It prevents the structural damage and vision loss. But one should always rule out any source of systemic infection and ocular infectious causes of uveitis before actually starting the immunosuppression in uveitis, because immunosuppression in unrecognized cases of infection can be catastrophic. But one must remember that the infection and inflammation frequently coexist. You can get active inflammation in cases of infectious uveitis also. So be careful while starting immunosuppressive. So the mantra here will be diagnose first, suppress later. Now, coming to the first category of drug, corticosteroid, we have local regional route. All of them actually causes the local immunosuppression, but that's a different topic. We will focus on the systemic immunosuppression here. Now, coming to that corticosteroid dynasty, we have so many drugs. You will see this list of corticosteroids available in your textbook. You have to remember that because the mechanism of corticosteroid is intracellular, the effect of corticosteroids persist even after the corticosteroids have disappeared from the circulation. Therefore, the duration of action of the specific corticosteroid is often based on how long the effect on the hypothalamus, pituitary, and adrenal axis persists, whereas the actual therapeutic action is longer. Now, HPA-axis, when we talk about that, you have to remember that oral corticosteroids are best taken as a single morning dose after the breakfast to mimic the physiological cortisol secretion and minimize the HPA-axis suppression. Now, why the prednisolone is preferred by the uveitis specialist or most of the people who handles the inflammation? Because the bioavailability of the prednisolone is high. Number two, unlike high-efficacy steroids like dexamethasone and prednisolone has a intermediate half-life of action, like 12 to 36 hours. So dose adjustment is much more easier. And also, the anti-inflammatory effects of prednisolones are greater than the anti-metabolic side effect. That's why we choose this drug. Now, when we talk about the steroid and immunosuppressions, there are two ways of doing it. In one way, we use suprapharmacological, very large amount of single doses for a short period. These are called actually pulse corticosteroid, usually very safe and avoid side effects like of long-term therapy and rapid anti-inflammatory benefits. I can give you an example. Following a 500 mg IV methylprednisolone dose, the concentration of the drug in vitreous peaks in approximately 6 hours in non-inflamed eye, and in case of retinal detachment, it peaks in the vitreous as quick as 2 hours. So that's why the pulse corticosteroid is often used in the management of sight-threatening conditions like macula-threatening choroiditis, optic nerve head inflammation, exudative retinal detachment, impending globe perforations. So due to the scleritis, these are the cases. Now, doses of the oral corticosteroid, we all know. Few learning points. The high dose of oral steroid for immunosuppression is to be avoided more than 1 month. Corticosteroid resistance is a sometimes very poorly defined term, but usually if the drug is not effective for 20 days, then we consider it as a corticosteroid resistance. More than 10 mg drug, still the recurrence is there. It's an indication for the immunosuppressive, and less than 10 mg is a threshold for successful steroid sparing. Many studies defined it as between 10 mg to 7.5 mg. As we highlighted, why we use weekly tapering drug? Because that stepwise equilibrium, it matches the 18 to 36 hour half-life of the prednisolone, which enables the safe 20 to 25% dose reduction in weekly tapering. And also that it is done without destabilization of the suppression of the Th1 and T17 cytokines and leukocyte trafficking. That's why we prefer weekly tapering of the drug. Now, coming to the corticosteroid, the postgraduates can remember it with a mnemonic called cushingoid. You know, always you can use this mnemonic so that you can actually, in exam, you can write about the side effect of the corticosteroid. Now, when to consider immunosuppressives, as I have already hinted in my last slide, it's the recurrent attack of uveitis in spite of being on oral steroid, resistance to oral steroid when it is not affecting, and the risk of steroid-related side effect, and also the children who are notorious to develop corticosteroid-induced growth retardation, steroid-induced glaucoma, and cataract. So if you want to take one pearl from here, one of the important pearl will be the children don't subject them to a unnecessary higher dose of corticosteroid. Now, there are some situations where the first line of immunosuppressives have been advocated. This includes Behçet disease, sympathetic ophthalmia, Vogt-Koyanagi-Harada disease, necrotizing scleritis, juvenile idiopathic arthritis, and chronic pars planitis in children. Many of these entities are highly recurrent in nature, so that's why it is actually some immunosuppressives is prescribed. Now, if we go into that, the roots of the therapy, you need to understand that most of the drugs available in our armamentarium are available for oral use. There are two immunosuppressives which are available for intravitreal use. One is methotrexate, another is sirolimus, and topical formulation is available for the T cell inhibitors like cyclosporine and tacrolimus. But unfortunately, we don't use them for uveitic control. So it is mainly used for the ocular surface related inflammation. Now, the pulse corticosteroid, we have a drug, immunosuppressive cyclophosphamide, which we'll be discussing in the subsequent slide. Now, one important point about this metabolism of this inflammatory anti-inflammatory immunosuppressives is all these drugs are primarily metabolized in the liver except methotrexate. Now, methotrexate is primarily eliminated unchanged by the kidneys. 80 to 90% actually eliminated by the kidney, and very few undergoes metabolism in the liver. But still, we are scared of the hepatotoxicity by methotrexate. Why? Because methotrexate accumulates in the liver as a methotrexate polyglutamate. So, which is why hepatotoxicity is a known effect and liver function monitoring is mandatory. Even the primary elimination route or the metabolism route is not liver. Now, few practical points about the immunosuppressive I want to highlight. The oral methotrexate, it is actually very good if we are using less than or equal to like at 15 mg per week dose. At 20 to 25 mg of the week, bioavailability of the drug reduces significantly and subcutaneous methotrexate is preferred. So because the bioavailability is much more compared to the oral dose of the steroid. And also postgraduate should understand and remember that folate 1 mg daily reduces the GI toxicity or mucosal toxicity. And these patients, while on methotrexate, there is no, they are not supposed to donate blood or plasma, and also absolutely contraindicated in pregnancy. Now, coming to the azathioprine, the thiopurine S-methyltransferase is a very important enzyme because it metabolizes the azathioprine into inactive forms. Now, interestingly, one patient in 300, this is homozygous enzyme, no, they are absent. So these patients are in increased risk of profound or sudden toxicity. So you can have two options. One, you can monitor these patients with blood count, or we can go ahead with the TPMT enzyme estimation test, which is little expensive, but you can actually order this test to find out whether the patient is having deficiency of this enzyme. Now, while doing that, if some patient is having additional gout or patient is on allopurinol, you need to be very careful because allopurinol inhibits the xanthine oxidates, which blocks the inactivation of the 6-mercaptan urine, which is a primary metabolite of the drug and can cause marked bone marrow toxicity. Now, coming to the mycophenolate mofetil, you have to remember that the mycophenolate mofetil should be taken in empty stomach because food decreases its absorption by 40%, and mycophenolate should be used in caution with patients with renal impairment and with gastrointestinal disorder, which might affect the absorption. Now, coming to cyclosporine, we don't use this drug as we were using it before, but few things that drugs like ketoconazole, itraconazole, macrolides, even the grapefruit juice, which are strong CYP3 inhibitors, they actually increases the serum level of cyclosporine to 2 to 5 times. So you have to be very careful. Nephrotoxicity is a major concern, which actually has limited its use. And also another important side effect is hypertension. Now, coming to the cyclophosphamide, if you see, the IV pulse steroid is preferred because it causes the disease control and reduces the chances of hemorrhagic cystitis, infertility, and malignancy versus the long-term oral therapy. So it also allows the IV therapy also allows the control hydration and mesna with the mesna co-administration, the risk actually comes down significantly. Now, coming to the side effect, few things you must know that the methotrexate causes the bone marrow suppression. So is the azathioprine. Both these drugs are actually known to elevate the liver function test also. The cyclosporine, already I have mentioned, and cyclophosphamide can cause bone marrow depression, also bladder cancer, hemorrhagic cystitis, and permanent inflammation. So whenever there is a question of immunosuppressive use, we should have some checklist. One is you need to know the side effects. You need to have a informed consent from the patient that they understood the risk and benefit of the therapy, and they will monitor the lab parameter. And also they should be under a care of a internist and physician for regular monitoring, who will take care of their parameters, vital parameters. Dose adjustment in special situation, which I have already mentioned, is very much needed. Whatever it is, as a ophthalmologist, you should monitor these patients very closely. You should advise them about their diet habit. When you are prescribing methotrexate as a thioprin, you have to tell them to limit or restrict their alcohol intake. And the risk of infection is very important. You need to inform all the patients, and few drugs, as I told, the methotrexate, azathioprine, even though there are some reports that azathioprine is found to be safe, but you have antimetabolite and patients with cyclophosphamide, you have to explain especially if the patient is from reproductive age group, about the contraceptions. Now, coming to that limitation, one thing you must understand about the immunosuppressions, that these are not drug of choice for acute site-threatening inflammation. Look at the onset of action of this drug. Methotrexate takes almost 2 to 3 months to start acting. Azathioprine, it can take 1.5 months, and methotrexate can take, mycophenolate can take almost a month. Now, this one study you all should know and know about the details of this study. This is called SITE study. It is the largest retrospective cohort study on systemic immune therapy in immunosuppressives. They have actually analyzed more than 7,800 patients with non-infectious ocular immune inflammatory disease in various anatomical type, like anterior, intermediate, posterior, and panuveitis. And they compared these subsets of the patients with a cohort of patients with ocular inflammatory disease who received the systemic immunosuppressive therapy, and the other group, actually same inflammatory disease, who did not receive any systemic immune suppressive therapy. And they also interestingly tried to evaluate the risk of overall mortality and malignancy. What they found that the methotrexate, azathioprine, mycophenolate mofetil, and cyclosporine, they have no increased risk of mortality or cancer-related death with the use of these drugs, whereas the cyclophosphamide, no significant increase in overall mortality was observed, but there was a possible increased risk of cancer with the use of drug. Now, coming to the other results, important results, immunosuppressive therapy associated with improved control of the intraocular inflammation and better visual outcome, including the macular edema involvement, and corticosteroid sparing success, like varied by the drug and uveitis type. Methotrexate and mycophenolate was most effective in anterior and intermediate subtypes, whereas the mycophenolate mofetil was effective in posterior and panuveitis. So when we talk about methotrexate and mycophenolate, there is another trial you should know, that is called the FIRST trial, the first line antimetabolite as steroid sparing agent. It's a randomized multicenter observer masked clinical trial where they analyze the patients by randomization, to which a cohort received the methotrexate 25 mg per week, and another cohort received the mycophenolate mofetil 3 gram per day. And the primary outcome they have measured with corticosteroid sparing action, and they found that methotrexate was non-inferior to mycophenolate for controlling the ocular inflammation, meaning both were similarly effective and neither was superior as a first-line immunosuppressant. So here you have to note the dose of this drug which was used in this trial, which is relatively little higher than we use in our clinical practice. Now, coming to that last phase of my this thing, so we have to understand that for the postgraduates, you need to understand that we have a corticosteroid, which is a workhorse in inflammation management. Then we have the immunosuppressives, which we can call the strategies, because we actually keep this drug and maintain these patients to prevent them from recurrence and further damage. Now we have another agent which is called a special task force, that biologicals. Now we'll be discussing about that, but for the postgraduates, you must know that there are drugs called the biologicals are biologically produced drug. So there are broadly two subtypes. One is monoclonal antibodies. You can actually make out which drugs are monoclonal antibodies by this suffix, that mab. So for example, ranibizumab, the rituximab, these are all monoclonal antibody. Now, if a drug is a fusion protein, now what is fusion protein? The protein created through joining the two or more genes that originally coded for separate proteins. So this fusion proteins you can make out if there is a sept in their name, like etanercept, aflibercept. So these are all fusion protein. Now then comes our drugs called the chimeric antibody. Now, the chimeric antibody means that antibody made by combining the genetic material from a non-human source, most commonly mouse, with genetic material from human being. So these are called chimeric. Now, how you can actually know these are chimeric? You will see that ZMAP. So rituximab. So these are the drug, actually you can identify easily the nature of the drug. Now, then comes the humanized. Now, what is humanized and difference between chimeric? Humanized are the antibodies from non-human species where protein sequence have been modified to their similarity to human antibody. That means we have taken antibodies from the mouse, but we have modified it to match the human antibody. So how you will recognize them? They will have the Zumab, like bevacizumab, tocilizumab. So these are the humanized antibody, monoclonal antibody. Now then comes the adalimumab and golimumab. These are the fully human antibodies. Now, if you look at this interesting chart, you will realize that the potential of immunogenicity, how it decreases when we use the fully human. But are the fully human antibodies are totally free? We'll discuss that in one or two slides later. Now, coming to that indications of that, there is no indications that we use that as a first line agent, but there are some conditions where nowadays people want to use that because considering the risk of failure with immunosuppressive agents, and so that they can preserve the loss of vision and the end stage or sequelae of the uveitis earlier. So this includes Behçet disease, juvenile idiopathic arthritis, though there is a growing evidence of using this drug, but methotrexate remain the first line of treatment of choice for these agents. Similarly, the necrotizing scleritis, sometimes we use them as a first line agents. There are also indications like HLA-B27, resistance cases of sympathetic ophthalmia, Vogt-Koyanagi-Harada disease, chronic disease, and non-infectious of uveitis, which is not responding to one or two immunosuppressives. We prefer to use the biological agents. Now, coming, as I have already mentioned, that how TNF-alpha, the cytokine, plays an important role. You see here what happens here. Cytokine TNF-alpha comes here and binds to two receptors, and which actually carry forward the inflammatory reaction to activate the cells. Now, here comes the TNF-alpha blocker. So TNF-alpha blocker, they does not allow the TNF-alpha to bind with the receptor. They compete with the receptor and bind with that. So that's how they prevent this connection and prevents the inflammatory process. Now I will be discussing the biological very selectively, 2-3 agents only. One is adalimumab. The adalimumab remains the subcutaneous injection, and you can see that it has a relatively faster onset, 5.5 days it starts acting. Now, as I told, though it is a fully human, they also develop anti-adalimumab antibodies, and one must actually realize that. And that's the reason sometimes we combine the methotrexate with adalimumab so that there is the development of anti-adalimumab antibody is less. Then coming to the another class, rituximab. So rituximab actually starts acting within the 4 to 12 weeks after the initial 2-dose cycle, and it's a good drug where we require the B cell depletion. Coming to the tocilizumab, it is IL-6 getting more and more popular in the treatment of uveitis. Now, when we talk about this, we need to know that advice trial. What is advice trial? Advice trial is adalimumab versus conventional immunosuppression for uveitis trial. So it compared adalimumab injections to conventional drugs like methotrexate or cyclosporine plus steroids in non-infectious uveitis. And they found that at 6 months, 69% of the adalimumab achieved inactive uveitis on low-dose prednisolone versus 54% on conventional immunosuppressive therapy. Another landmark trial is Sycamore trial. The Sycamore trial tested adalimumab plus methotrexate against placebo plus methotrexate in children. So they found that adalimumab group had far fewer treatment failure compared to the methotrexate alone with the placebo group. So they found that adalimumab and methotrexate is a first-line biologic for active GIA uveitis, which is failing with the methotrexate treatment alone. So coming to the last category of the JAK inhibitors, we have already explained that what is that the pathway. So it is FDA approved for the treatment of the rheumatoid arthritis and psoriatic arthritis. The tofacitinib, it's a very small molecule and more likely to cross the blood-retinal barrier, and added advantage is that over the TNF-alpha inhibitor is that it is well absorbed orally and relatively less risk of granulomatous disease such as tuberculosis. The scope of topical applications is higher in other subspecialty. So we hope that it will be available in ophthalmology in near future. Now for the postgraduates, I want to highlight this study because it's very important as a postgraduate and those fellows who are observing that the critical thinking is very important when you read a study. Now this is a study you see, it's called oral surveillance study. So it's basically a tofacitinib safety trial. What they did a large randomized open level post-marketing safety trial. It's called phase B. And they selected a population of rheumatoid arthritis patients over 50 years. And they kept one cardiovascular risk factor in this category. So the risk factor were the smoking, hypertension, hypercholesterolemia, diabetic mellitus, family history of premature coronary artery disease, extra-articular rheumatoid arthritis prior this thing. So they randomized this drug with tofacitinib, the TNF-alpha inhibitor. The sample size was 4,362 patients with active rheumatoid arthritis despite methotrexate. And the duration was almost 4 years. They tried to create actually a real-life scenario with this drug, which is called phase 3B trial. So why I am highlighting this, when you read a paper on study, you need to have a critical thinking and analyze the paper rather by going into the details or the just result by the study. So Feb 2019, this study came up with the observation that there is an increased pulmonary embolism with mortality with 10 mg BID dose. So the dose was reduced to 5 mg. In July 2009, FDA issued a box warning for the blood clots and death with 10 mg BID dose. And there was a safety concern about this drug. So, and people actually started thinking about that this drug is causing so much of complication here. Now, if you look carefully and try to analyze it, you will see that the serious adverse effect was much more common with this tofacitinib versus TNF-alpha. Now, if you remember, the population here they have selected for the study, it included 4,362 patients who had this significant risk factor. At least one significant risk factor was there, like smoking, hypertension, hypercholesterolemia. So these patients with that, they found that the risk was greater in older patients, the established cardiovascular risk factor. And there was a minimal risk when there was a no significant difference and TNF alpha. So it's very important when you analyze a study, and you should study the what population is we are studying with for a drug, and what risk factor we are including before analyzing the risk factor of a particular drug. Now, coming to the last slide, the therapeutic immunosuppression uveitis is all about the risk, adverse effect of the treatment, and balancing the benefit of saving the site. As I told you, this is immunosuppression. So, for example, I'll explain it in much better way with this WhatsApp message. For example, there is an injury here, and you see immediately there is an injury. It is viewed by all the fibroblast, macrophage, neutrophil, mast cell, and platelets. They immediately be aware that there is something has happened and there is chance of some infection getting entry into our body. So with the immunosuppression, this becomes faded, and this cells actually enter cellular mechanism actually becomes little drowsy, and the response can be very sluggish. So there are increased chances of risk infection, and the risk is that the corticosteroid elevates significant bacterial risk. Azathioprine and mycophenolate causes significant secondary infection. Herpes zoster can can actually predominates in patients with JAK inhibitors. CMV retinitis, though common with post-local immunosuppression, can also occur from in systemic immunosuppression. And most importantly, the TNF alpha. As I talk about TNF alpha, you have to remember that TNF alpha is a primary defense system against the Mycobacterium tuberculosis. So when in a country like India, you are using TNF alpha inhibitor, these are the patients who are at highest risk of tuberculosis. So you need to always have a high index of suspicion and close monitoring for this drug. So other side effects are there, like malignant risk, cardiovascular effect, and other toxicities. But last, that you need to understand that it's not only the cost, risk and benefit, it's also about the cost. So these are the drug cost. Only the biological, which has become available and more actually easily available, still it's beyond the reach of many middle class people, or people with a lower socioeconomic or lower income. So these are expensive drugs, so you have to very judiciously. So as I told finish, I want to highlight this: the old drugs shot in dark, the new ones light up the path with a spark. So choose wisely. Remember the word by the Hippocrates: wherever the art of medicine is loved, there is also a love of humanity. So same applies with the immunosuppressions. Always keep your patients the condition, keep them all the options, and actually practice this art of immunosuppressions with love and care. Thank you.
Thank you so much, Partho sir, for your wonderful talk. Very comprehensive and insightful. You completely outlined the entire inflammatory cascade with such detail and lucidity, especially the WhatsApp analogy. It was very helpful to understand. So thank you so much, sir. I'd like to ask a few questions to our panelists. We can start with Dr. Bala, sir. So whenever we're faced with cases like VKH, I'm taking the most common sort of autoimmune cases. What would be your choice of immunosuppression in these cases?
Yeah, thanks a lot for the wonderful question. I really appreciate the presentation by Dr. Partho. So in my practice, we start with the level 1, 2, 3, 4. Level 1, we have methotrexate or azathioprine based on the affordability of the patient. And of course, the parameters, the workup we undergo. And most often, along with the immunosuppressant, the steroids are also started. And once, if they don't respond to level 1, we go to the next level, which we have as mycophenolates and cyclosporine. And the next level we have is that chlorambucil or the cyclophosphamide. For very sight-threatening conditions, we sometimes admit the patient and give IV cyclophosphamide. This IV cyclophosphamide is the only immunosuppressant that is going to have an immediate onset of action. So we had a lot of good response whenever there is a sight-threatening condition. Of course, it needs careful counseling also. Hope I answered your question.
Yes, sir, definitely. And so, in such situations, once we start immunosuppression, when we counsel the patient, what do you tell them? What would be the optimal duration of immunosuppression? Since we need to give them a timeline, how long they would have to consider the medications. So,
Yes, this is a very, very relevant, pertinent question in the sense that we have a cutoff like as Dr. Partho highlighted, these immunosuppressants are like train. They have very slow onset of action, and even when we stop, also they keep acting for the next 6 to 8 weeks. So we factor in that in the sense that along with those period of 6 to 8 weeks, we also give steroids. So in that intervening 6 to 8 weeks, we assume that the drug is not going to act in the eye, and we factor in the dosage of the oral steroid into consideration. So we tailor make the dose adjustments for the initial 6 to 8 weeks with the non-immunosuppressive, which is steroid, the workhorse, which Dr. Pardo clearly mentioned. And for very important conditions like JAR basis, we start with the adalimumab and biologicals. And we explain them that these drugs are for long term, and only after 6 to 8 weeks we factor in the drug would have started. By that time, the inflammation would have probably reduced with our steroids, and if needed, a local supplementation.
so,
So
but
our plan is ready.
and for how long do you tell them that the duration of immunosuppression for 6 months, 1 year, or longer?
Yeah, that depends on the predictors of inflammation or predictors of the disease the patient is going to have. For example, we have predictors of inflammatory activity in JA different from VKH, from sympathetic, or the other autoimmune specifics. So if we have a lot of predictors, maybe we will have it for a longer duration, and how the patient responds also. So we normally it takes 1 to 2 years, even longer, some of the patients. Depends on the course of the disease, during which how the drug compliance, all the different factors act into account. And while tapering it, we want a period of minimum 3 to 6 months before a dose reduction is possible. We can't abruptly stop. So for having a dose reduction, a minimum of 3 to 6 months is essential. For a very aggressive condition like sympathetic or we stick to 6 months. However, for other conditions, if it is for a secondary indication, that means not a primary indication for immunosuppression, we will have the 3 months as cutoff to go for a dose reduction, and then gradually taper it. It will take months, and unless there are no other contraindications. For example, dose limiting side effect of methotrexate is interstitial lung disease, or if there is a hepatotoxicity that we are forced to stop, we'll have to think otherwise.
So thank you, sir, for your insights. And I'd like to ask one more question to Dr. Reema. Ma'am, what's your experience with newer immunosuppressive medications like JAK-STAT inhibitors and biologicals? When do you prefer these agents?
Hi, Aditya. So, biologicals, I think now are becoming the kind of primary treatment in many of the GIs. So we don't really wait for after starting methotrexate. If the response is good, it's fine. But if the response is not good, the patient, our rheumatologists prefer to put them on adalimumab. That is the preferred biological. And JAK inhibitors, of course, are reserved for very, very recalcitrant cases. I mean, this is a stepwise. It's never a first or a second choice. I mean, we start with the first choice for us is usually azathioprine or methotrexate. Patient doesn't do well, we can still go to biologicals. So JAK inhibitors are the end stage immunosuppression, but we have seen them, and I think the commoner indications, if we have to talk in uveitis, are one of those patients with angst spondylitis. They're really bad and they have multi-system involvement. This is one condition where we consider JAK inhibitors.
Thank you, ma'am. Thank you for your insights. Dr. Kalpana, ma'am, would you like to share your views on JAK-STAT inhibitors and their usage?
Yeah, so JAK inhibitors has been now in practice, like quite commonly used. As Partho put it, actually, the dose is something which is very, very important. And right now we have about 52 patients with on JAK. Generally, we give adalimumab. I mean, we offer adalimumab in those cases with refractory uveitis. And when I say refractory uveitis, it will be those who have failed a combination of immunosuppressions. So then we switch them to biologics. So at that point of time, for us, the decision making again becomes difficult. I mean, is given to the patient whether he wants adalimumab or tofastinib, because as we all know, adalimumab is FDA approved, and tofastinib, again, it may work, it may not work. So ideally, we give the choice, and it depends on, basically the decision is economic, because most of these patients are not funded by insurance. They are self-funding the treatment. And as we know, once we start biologics, it's difficult for us to say how long they need these medications. So we give the choice to the patients, and most of the time we tell them very clearly the pros and cons of each. And if they want to try, we would try tofastinib for some time. If it doesn't work, then we switch them to adalimumab. So I think in our series of patients, many of them would like to try tofastinib, which has worked significantly well in conditions like what Rima mentioned: ankylosing spondylitis, sarcoidosis, refractory macular edema due to sarcoid. They have worked very well. Rheumatoid arthritis, it works very well. And in those cases which are idiopathic, that's the one which is the problem one. So we give a trial. If it doesn't work, then we switch them to adalimumab. The problem with the tofastinib is the cost is quite low, and now even the original molecule is quite low. So that becomes a preferred option, but the chances of viral infections are higher with tofastinib, and that's something which we need to keep in mind. So many of our patients are given prophylactically zoster vaccinations and pneumococcal vaccinations before we start these medications.
Sure, ma'am. Thank you so much for your valuable insights. I would now like to call upon Dr. Arshi, ma'am, to start your presentation.
Hi, thank you, Aditya. I'll just share my screen now. Can you see my
Yes, ma'am, we can
slides?
see. Yes, ma'am.
Okay, great. So a very good evening to all of you. I would like to thank AIOS for giving me the opportunity to speak on this platform. And I'm very honored to follow JB sir and Partho sir after their wonderful presentations. I would like to thank our expert panelists here who have taken out the time and who will be giving their kind comments at the end of my presentation. So without further ado, let me begin my presentation. And I wanted to show you this case example of this patient. She's a 20-year-old patient who presented to us. And as we see the right eye, we see that it is like a disorganized anterior segment. And we also see a lot of like post-peripheral anterior synecdoche forming. We see some membrane across the pupil. A softer eye, already kind of a pre-thusical eye. The other eye has already been operated elsewhere. We see pseudophakia, and along with that, we also see still signs of active inflammation. The vision in the left eye is also only 3/60. The fundus view was quite hazy. And when we are able to see the fundus, we see a lot of vitritis, a hyperemic disc, and a lot of scarring at the macula, which the OCT is also able to pick up very well. So this patient has this disease since she was 15 years of age. So for the last 5 years, she has not been put on any oral steroids, any long-term immunosuppressive therapy, and she has also been subjected to a left eye cataract surgery. So on the other hand, now we see a patient who has been treated for lupus and has developed toxicity because of hydroxychloroquine. The multifocal ERG clearly shows a loss of the foveal peak. And this other picture shows a patient who has developed steroid-induced CSCR. In the other eye, he has intermediate uveitis. So these are the extremes of complications which one would see in the uveitis clinic. If the patient is untreated, it leads to severe visual loss, morbidity, not only affecting the eye, but also overall affects the mental health of the patient, affects their livelihood, and also in turn affects their family. So the topic I have chosen for today is complications in uveitis. So complications in uveitis, to study the word complications, it's a small word, but it basically encompasses a plethora of structural and physiological changes which happen in the eye in patients with chronic uveitis. The word itself means to fold together, that is, you entangle or you intertwine. So this is the basis of my talk today. To give you a very quick overview of complications in uveitis. So overall, all patients who develop uveitis may have complications in almost 30 to 60% of patients, which is a very, very high number. These complications can rapidly become vision threatening in 25 to 35% of cases, whereas even legally blind status may be seen in 10 to 15% of patients during the course of follow-up. So why do patients actually develop complications? So the important thing to understand here is that whenever there is any chronic inflammation in the eye, there is a breakdown of the blood aqueous and blood retinal barriers, which are the key factors which maintain the quiescence of the eye, which contribute to the immune barriers in the eye. So whenever there is a breakdown, it leads to alteration of normal physiology and structural changes. So various risk factors we can think of. Why would patients or who would develop complications? First of all, if there is a younger age at presentation, so in the pediatric age group, the risk immediately shoots up to 50 to 80% incidence of complications. If there is involvement of the posterior segment or pan-uveitis, definitely, because it could become macular threatening or optic nerve threatening. It can lead to increased visual morbidity. If there is chronic or recurrent inflammation, or there is delayed or inadequate treatment, that would definitely increase the risk of developing complications. Also, we need to remember that there may be specific entities which are more prone to develop complications. For example, conditions like Behçet's disease, where optic nerve involvement could be very early and can lead to a lot of visual morbidity. So before we analyze the different complications, it is important to know the Sun classification, especially for postgraduates, to remember that uveitis could be anterior, intermediate, posterior, or if all the parts of the uveal tract are involved, it could be called as panuveitis. So once you understand the anatomical localization, it becomes easier to understand which complication is happening in which particular kind of uveitis and why. So when we compare the incidence of complications across these various categories, we see that anterior uveitis, the incidence could be between 30 to 50%. Increases in patients with intermediate uveitis are approximately 50%. Posterior uveitis, as I mentioned, there is involvement of the macula or optic nerve. The risk increases further, and panuveitis, as is expected, has got the highest incidence of complications. So when you analyze the different kinds of complications which can happen, the most common reported complications are either a cataract, secondary glaucoma, or cystoid macular edema. So another way of classifying complications in uveitis would be to understand the mechanism which is going on, or the process which is going on in the eye in such eyes. So let us look at them in a different way. If there is fluid buildup in the eye because of any reason, it could result in cystoid macular edema or exudative detachments and even glaucoma. If any sort of adhesions form over a period of time, it could be in the form of synechia, which is changes like vitreous debris or tractional retinal detachments, and even cataracts can form because of these chronic adhesions. Structural changes in the eye can happen. For example, epiretinal membranes, very commonly seen complication of uveitis, macular holes, rhegmatogenous RD, thinning or atrophy of any part of the eye, of any coat of the eye, can result in a structural change and ultimately even resulting in perforation. Tissues may get added into the eye in the form of either a band-shaped keratopathy or lipid deposition. On the other hand, there may be deletion of structures which can result in hypotony. If there is hypoxia leading to chronic angiogenesis, you may end up with rubeosis iridis, macular neovascularization, and even vasoproliferative tumors. And lastly, it could also be treatment related, wherein even though your best interests are there, the patient may develop treatment related complications like cataracts, glaucoma, toxicity of the macula, or toxic optic neuropathy, and even CSCR. So these are the various complications which we will discuss over the next few slides. I will try to put it in a manner going from anterior to posterior for easy understanding. And I would also like the postgraduates to note the various use of ancillary investigations as we go, to understand the role of these investigations in diagnosing and monitoring patients with complications. So first is coming to the sclera. So the sclera is the outer 5/6 of the eyeball, and it is the outer coat of the eyeball. It is primarily composed of collagen bundles. It is rich in nerve supply, but it is avascular. So the important thing to understand is that when there is recurrent scleral inflammation, when there is recurrent scleritis, you may develop scleral thinning over a period of time, which leads to underlying uveal tissue reveal, which leads to this typical bluish hue you may see in a patient with necrotizing scleritis. Now, when this process goes on unchecked, the patient may develop scleral ectasias and staphylomas, ultimately resulting in scleral perforations. So this is the anterior segment OCT of a picture who has chronic scleritis. And we can also see here the corneoscleral wimble thinning along with thinning of the sclera in this part. So what are the various complications which can happen in a patient with scleritis? So look at the adjacent structures. If the adjacent cornea is involved, as I mentioned, it could result in thinning of the cornea. In the adjacent anterior chamber, you can end up with anterior uveitis and secondary glaucoma. And in cases of posterior scleritis, because of the adjacent structures getting involved, you may see optic nerve edema, cystoid macular edema, and they can even present with exudative detachments in severe cases. So this is the example of a patient who has come with infective scleritis, and we can clearly see the pus point here. So this patient also had a large infective focus near the cornea. A glue BCL has already been done for the first area. And you go on to see that as the lesion heals up after appropriate anti-infective agents, you see thinning of the sclera and thinning of scarring of the adjacent cornea as well. So ultimately, when you have patients with scleritis, classify whether it is infectious and non-infectious, and the only way to prevent complications is go for aggressive control of inflammation, whether it is with the appropriate autoimmune agents, anti-inflammatory agents, or the appropriate anti-infective agents. If there is impending perforation, you may require scleral patch grafts or amniotic membrane transplants. Otherwise, the end result could be something like this, where there is a complete corneoscleral melt in a 50-year-old patient who was C-ANCA positive. So now let us move over to the next structure, that is the cornea. So it forms the anterior 1/6 of the eyeball. It is a transparent avascular structure and is very important as it is one of the first refractive surfaces of the eye. So any change here in the cornea is definitely bound to result in visual morbidity. So let us look at the various complications which can develop in patients who have corneal issues. So the first photograph here shows a patient who was a known case of HSV keratouveitis, but what was operated elsewhere without the cover of any antiviral agents, without appropriate anti-inflammatory agents, and presented to us like this with hyphema, severe fibrinous inflammation in the anterior chamber, and a lot of corneal involvement as well. So after managing him appropriately with antivirals and limited use of topical steroids, the condition resolved. And although the patient has now developed corneal scarring and has also gone on to develop corneal thinning. So this is very important to know that these patients can develop corneal changes over time, which can result in visual morbidity. This is another example of a patient who has tubercular intermediate uveitis, but also came with interstitial keratitis, as you can see here in the first photograph. Already there are new vessels growing into the cornea. After appropriate treatment with ATT and oral steroids along with topical low-strength steroids, this patient went on to develop scarring and lipid deposition. If the lipid deposition, on the other hand, continues to be very aggressive, these patients will develop a total lipid keratopathy. And lastly, band-shaped keratopathy is a very important thing to remember as when you're looking at the cornea, especially in children or in patients who have chronic uveitis or JIE-associated uveitis. So what happens here is that there is deposition of calcium in the superficial layers of the cornea. So this, on this side, on the left side, is a normal histology of the cornea. And on this side, you see a lot of calcium deposition in the Bowman's layer and in the superficial stroma. So classically, when you see this, you see it in the interpalpebral zone, as you see in this picture. And there is usually a clear interval between the limbus and between these deposits. You may see a typical Swiss cheese appearance. So this is a spotter. This is something which one cannot miss. So the way to manage this would be either you can scrape it or you can subject this eye to EDTA chelation, which definitely results in very good visual improvement for the patient. So next is moving over to the next structure, that is the iris. So iris can be considered to be in the hot seat as far as complications in uveitis are concerned. It is a delicate structure which demarcates the space in front of the lens into the anterior and the posterior chambers. So iris is very important because it constitutes the blood aqueous barrier. The vessels in the iris are responsible for giving the eye its special status where there is no active inflammation in the eye. The aqueous is clear, there are no cells in the eye. So whenever there is a breakdown of the blood aqueous barrier, now problems start developing in the anterior segment of the eye. Over time, the iris and the ciliary body may atrophy and fibrous tissue may replace the stroma of these structures. So iris atrophic patches can develop over time, and many a times these are very, very diagnostic of the kind of inflammation that may be going on. But typically, you may see iris atrophic patches in any patient with chronic anterior uveitis. In viral uveitis, you may see sectoral defects like in herpes zoster. It could also be iatrogenic, that is, during cataract surgery, for example, if there is manipulation, you may develop iatrogenic defects. On the other hand, you may also see pigment loss, what we call as a washed out iris. You may see that in any patient who has got long-term disease, where there is loss of pigment from the posterior epithelial layer of the iris, especially in patients with fuchs or viral anterior uveitis, as you see in this patient where there is associated corneal edema. It may happen in also non-uveitic conditions like pigment dispersion or pseudo-exfoliation glaucoma. So now next is moving over to the adhesions part of it. So the iris, because it is a thin and delicate structure, any inflammation in the eye when there is cellular proliferation, it will lead to a high protein content in the aqueous. So now this will result in the iris forming adhesions to either structures anterior to it, which could be the cornea or the trabecular meshwork in the periphery, or it could be the lens behind it. So when the iris adheres to the lens, it is called as posterior synecdoche because it is posterior to it. So initially there will be adhesions, but later on fibrovascular organization will develop. So this is the example of a patient who has a classical broad-based posterior synecdoche, which one may see in patients with tubercular uveitis. So on the other hand, if the iris now comes in contact with the peripheral cornea and blocks the peripheral trabecular meshwork, we call it as a peripheral anterior synecdoche. So this is very important because this is going to block the normal drainage of aqueous through the trabecular meshwork and can result in secondary glaucoma very, very rapidly. So patients who have conditions like ankylosing spondylitis also go on to develop peripheral anterior synecdoche and secondary angle closure glaucoma very, very quickly. So once now a significant part of your trabecular meshwork is blocked, for example, if it is already a more than 270-degree block, you may have to give the aqueous another alternate pathway to drain out. Either it could be through a YAG PI, a surgical PI, or you may even require filtration surgeries. So here, to understand what happens when there is a peripheral anterior synecdoche or when there is ring synecdoche especially. So by ring synecdoche, I mean that as you see here, the iris is completely 360 degrees adherent to the lens behind it. This is called as a ring synecdoche. So when that happens, there is increased pressure in the posterior chamber as these arrows show. So now this leads to a bulging of the iris. And if this process continues unchecked, you see now that the peripheral iris goes up, there is so much of bowing, and it blocks the trabecular meshwork there. So this condition is going to definitely result in high intraocular pressure, and this is clinically visible as iris bombay, what you see when there is a very shallow anterior chamber towards the periphery and slightly deeper in the center with 360 degrees posterior synecdoche. So the only way to relieve this condition is you may have to resort to a laser iridotomy. And if a patient has chronic inflammation, unchecked inflammation, the PI gets blocked repeatedly, you may also have to take the patient up for a surgical PI. On the other hand, when there is chronic inflammation, you may develop a condition called as rubeosis iridis. That means new vascularization of the iris. So it is important to differentiate it from normal vessels in the iris stroma because the iris is a vascular structure. There are vessels present even normally. So you need to differentiate rubeosis from already present existing vessels. So rubeosis would develop whenever there is ischemia in the eye. So your inflammatory pathways dysregulate the angiogenic mediators, the pro-angiogenic mediators increase, and it leads to the development of these new fine vessels, which you can see initially very close to the pupillary border. You may even see new vessels in the angle. So a routine gonioscopy is also mandatory to pick up early neovascularization. So once you have picked up these vessels, it is important to know that this can go on developing into a full-blown neovascular glaucoma. As you can see here, massively thickened vessels. You also see eversion of the pupillary margin, and this condition I will be discussing next. So, as I was saying, neovascular glaucoma is a big threat to vision, and intraocular pressure may require aggressive management. So once this process has started, you may see a fibrovascular membrane on the anterior surface of the iris, which leads to tractional forces, and it will lead to an eversion of the pupillary margin, because this brownish layer that you see is essentially the posterior pigment epithelial layer of the iris, which is the posteriormost layer, and it has just gotten everted at the pupillary margin, and so you are able to see it anteriorly on the slit lamp. So this is a progressive condition and can be seen in any patient with chronic uveitis. So next is now moving over to the pupil. So the pupil, as we all know, is a small aperture in the iris. And as we have seen, conditions like seclusio pupillae may develop, which can result in iris bombing. So similarly, there is another condition which is called as occlusio pupillae. So it is important for postgraduates to differentiate between the two. Occlusio pupillae is usually a later sign of the disease, when there is a complete plastering of the iris to the lens behind it. So now here, the anterior chamber is deep. So this is as we saw the picture earlier. So now next is moving over to the lens, which is an avascular transparency in the lens. We call it as a cataract. Unfortunately, in uveitic eyes, it can develop because of the inflammation itself and also because of treatment, as we see in both these pictures. So this is a patient who has come to us with Fuchs uveitis. You can see the typical keratic precipitates and a near total cataract. And on the other hand is a patient who has been treated for anterior uveitis with multiple courses of topical steroids and has developed a steroid-induced cataract. So why this is important is because cataracts over a period of time will limit the visualization of the posterior segment, making it difficult for you to give the appropriate therapy, and of course leads to a loss of vision. So meticulous planning is required for removal of cataracts, especially in uveitic eyes, because they may be associated with other structural anomalies like posterior synechiae, glaucoma, or even hypotony. On the other hand, now, if the patient has already been operated, he can develop intraocular lens related issues as well. So over a period of time, you may see the intraocular lens developing deposits, or there may be the development of optic capture, posterior capsular opacification, and even anterior capsular phimosis, all of which will result in a loss of vision. So it is very important to keep in mind that when you are taking up a patient with uveitis for cataract surgery, IOL placement has to be done into the bag and never into the sulcus. Operate on an eye which has got disease quiescence for at least 3 months to prevent all these complications from developing. But even though you may try your best, over a period of time, many a times in uveitic eyes, you may see something like this. So this is the example of a patient whom I had operated upon. She has a past history of ARN, and 8 years post cataract surgery, she started developing a dislocation of the entire bag and IOL complex. So we followed her up over time because she was maintaining good visual acuity. The IOL was still in the visual axis and there was no retinal disturbance at all. But over time, we see a progressive dislocation of the entire thing. So this patient was then taken up for surgery where the entire bag and IOL complex was explanted and a scleral fixated IOL was done, and she continues to do well now. So now next is moving over to the vitreous, which is actually one of the largest parts of the eye. The intermediate contributes to the intermediate part segment of the eyeball. So it is again normally a transparent structure, and that is how it got its name, because in Latin it means glass. So unfortunately, when you are dealing with patients who have uveitis, especially intermediate uveitis or panuveitis or retinal vasculitis, the vitreous may turn turbid, hazy. So either the patient can come to you with vitreous hemorrhage, which can be the end result of any patient who has vasculitis of any sort of etiology, or post-retinal vascular occlusions when there is proliferative change in the retina and results in the development of new vessels. On the other hand, patients who have chronic intermediate uveitis and pars planitis, and sometimes even patients with toxoplasma retinochoroiditis, the vitreous may develop a lot of opacification as we see beautifully in this picture, so many peripheral membranes and pars plana scarring. At the same time, when we are talking about the vitreous, I would also like to talk about cyclitic membranes. So what are cyclitic membranes? As the name suggests, cyclitic. So it originates from the ciliary body region. So I have put up a UBM picture here for you to see. So you can see this membrane originating from the pars plana region, and it goes across the lens. So when this develops over a period of time, this may lead to contraction of the membrane, which can result either in ciliary body traction and can also result in peripheral tractional retinal detachments. So when there is enough traction or pull on the ciliary body, ultimately it may result in ciliary body shutdown and hypotony, which is one of the most dreaded complications you can come across in a patient with uveitis. So now let us move to the posterior segment. So let's talk about the macula first. So the macula is the part of the retina which is responsible for the central 15 degrees of your visual field. So any complication here, any long-term sequelae here is bound to be visually significant. So these are the various complications one can come across in the macula. So it can range from macular edema, macular neovascularization, exudative detachments, and hard exudate development, epiretinal membranes, detachment, that is a tractional retinal detachment, or what we can call this as a vitreomacular traction, ultimately resulting in a macular hole. So cystoid macular edema is the first thing I would like to talk about because it is one of the most common complications you can see in a patient with uveitis. It is more commonly seen in patients with intermediate uveitis and panuveitis. So the risk can be as high as 40 to 50%. So it is important to keep a lookout for it and to understand why this develops. So this diagram shows it beautifully. So basically, whenever there is a breakdown either of the inner retinal barrier or of the outer retinal barrier, you may develop fluid collection, especially in the outer plexiform layer and in the inner retinal layers. And this can be picked up clinically. Either you can do a good slit lamp biomicroscopy and use a 78D or a 90 diopter lens, or you can also pick it up on indirect ophthalmoscopy. So if you illuminate the retina with the beam being at a 30 degrees angle, you can pick up these cystic spaces beautifully. Before that, the patient can come to you with a complaint of reduced reading vision, or reduced reading speed, or reduced contrast sensitivity. So it is very important in patients with uveitis to also keep a track of their near vision, which will give you the first clue that the macula may be affected. Of course, along with the clinical examination, we have wonderful imaging techniques available now like OCT, which helps in structural delineation of the tissues, and you can clearly, beautifully see these cystic spaces which develop. And angiography, on the other hand, can pick up leakage at the macula in the form of this petaloid pattern classically described as, which is seen in patients with CME. And this is typically because of the arrangement of the fibers of the outer plexiform layer at the macula. Another visually devastating complication, I would say, is macular neovascularization, which can develop in any patient who has long-term posterior uveitis or panuveitis. So these patients can again present to you with symptoms like blurred vision and metamorphopsias. So you see here this patient who has an old toxoplasma heel scar and has gone on to develop this lacy network here along with a subretinal hemorrhage. So why these membranes develop? So whenever there is chronic inflammation, it can result in a breakdown or break in the Bruch's membrane or in the RPE. And this can lead to new vessel growth either into the sub-RPE space or into the subretinal space, as we can see here, this membrane, which is associated either with subretinal fluid, it could be associated with subretinal hemorrhage. So these are all signs of activity of the macular neovascularization. So along with the clinical examination, fluorescein angiography is a very wonderful way to pick up these membranes. So these will look at the early phases and at the late phases both. So because these will start leaking from the early phase itself and continue to leak till the late phase and appear to be usually described as lacy hyperfluorescence. OCT is a non-invasive way, a wonderful technique to diagnose and monitor these lesions. And now OCT-A is also available, which picks up these lesions, as you can see here, this network of vessels beautifully. Epiretinal membranes, as I was saying earlier, is a very, very common complication which can develop in any patient with uveitis. So the incidence is almost as high as 10 to 25%. So it's an avascular membrane. Usually they are asymptomatic, but if they become significant visually, the patient can present to you with metamorphopsia. The investigation of choice here is OCT. with this, you can serially monitor these patients and look for the development of traction on the retina or a decline of visual acuity. At the same time, these patients who have macular issues like macular edema can go on to develop complications like macular holes, although rare. But whenever there is a de-roofing of the cystoid spaces in chronic CME, you may end up with something like a macular hole, as you can see in this OCT, and these patients will definitely require VR intervention. So now let us move over to the retina. So the retina is a very important structure, as it constitutes your outer blood retinal barrier. So whenever there is any breakdown here, or if there is any impaired flow to the retina and hypoxia ensues, you will have release of pro-angiogenic mediators, which can further accelerate the process of the retinal barrier breakdown, and it can result in either neovascularization, or preceding that you may develop ischemia. So what are the classical features of retinal ischemia? So you can see here in this angiography, so this is a photograph of a 12-year-old child who has presented with bilateral loss of vision, showing extreme large vessel involvement. You can see the typical vasculitic staining and beading of the vessels, discrete, but at the same time, you see this entire posterior pole area, which is dark because there is reduced blood supply, reduced perfusion. So this is called as a capillary non-perfusion area. So you can pick this up beautifully on fundus fluorescein angiography. So these patients now go on to develop retinal neovascularization. So this is another example of a patient. You can see the leaking NVE. This patient has already been lasered, very well lasered. And so this will arrest the development of the neovascular process. Retinal ischemia and neovascularization can be very commonly seen in these conditions like Behçet's disease, highly prone to develop neovascular changes, retinal vasculitis of any etiology. You could be dealing with lupus retinopathy, which is again very prone to develop retinal ischemia. And even infectious conditions like acute retinal necrosis can go on to develop ischemia very, very quickly. This is the example of a patient with Behçet's disease. So you see the massive disc whitening and pallor along with multiple sclerosed vessels. So the OCT picks up the foveal thinning and the retinal thinning beautifully. And at the same time, OCT-A now is able to tell you, this is the deep capillary plexus scan, which shows a complete wipeout of the perfusion to the central retina, which is responsible for the poor visual outcome in this particular patient. Next is moving over to retinal detachments. So retinal detachments, as you all will know, broadly speaking, it could be rhegmatogenous, tractional, or exudative detachments. But it is important to note that many a times in uveitic eyes, you may have a combination. Many a times tractional detachments and rhegmatogenous detachments may happen at the same time. So let us have a quick look at these. So exudative detachment means whenever there is massive influx of fluid into the below the retina, which is resulting in this particular detachment. As you see in this patient who has forked Koyanagi-Harada disease, the optos picks it up beautifully. So the way to diagnose is either on a clinical examination, you examine the patient in both sitting and supine positions and look for movement of the fluid, and that is your exudative retinal detachment. On the other hand, you can also resort this patient to an ultrasonography and again document the presence of shifting fluid in sitting and supine positions. So you can see exudative detachments in patients with BKH, sympathetic ophthalmia, and as we were discussing earlier, even in patients with posterior scleritis. On the other hand, now, when there is no fluid involved, over a period of time, when there is chronic inflammation and ischemia, fibrovascular proliferation may develop, and this can result in vitreoretinal traction, which is called as a tractional retinal detachment. So again, this is very commonly seen in patients whenever there is any sort of vasculitis, Behçet's disease, patients who have toxoplasma or toxocara-related posterior uveitis, and of course, chronic intermediate uveitis. Rhegmatogenous RD in uveitic patients may be rare. You may see it very commonly in patients who have infective retinitis or panuveitis. So it is important to know that these are difficult conditions to treat. A patient with ARN or CMV retinitis may come to you with a rhegmatogenous RD, but the key thing here that it is an inflamed eye. Usually it goes against our understanding and teaching to operate on an inflamed eye, but these are few instances where one would like to intervene early, and surgical repair, although it may be difficult, but may be the only way to settle a rhegmatogenous tear and detachment. Rare complications, again, could be something called as a focal nodular gliosis, as you can see in this patient, which is term is also a vasoproliferative tumor. So these are these kind of yellowish pinkish lesions which can develop in the periphery and are most commonly seen in patients with intermediate uveitis or vasculitis. They are usually peripheral lesions, but it is important to know that these should be picked up in time because they have a high propensity to cause macular issues like macular edema or macular exudates, which are indirectly responsible for loss of vision. This is another example of one of a very, again, devastating complications. You can see the extensive subretinal gliosis and scarring which has happened in this patient with multifocal choroiditis and panuveitis. So this is one of the, again, a very disheartening thing to see because there is nothing much you can do for this patient anymore. Now moving over to the optic nerve. So the optic nerve, optos in Greek, it means seen. So the function of the optic nerve is that we see. But unfortunately, the optic nerve sometimes may be an innocent bystander of inflammation which is going on in the eye. You may see it to be hyperemic with dilated capillaries on the optic nerve head surface. An important investigation in such a case would be the use of a fundus fluorescein angiography. You may see leakage from the disc capillaries starting from the early phases itself, going on to the late phase, which is an indirect indicator of disease activity. And we do use it as a marker of disease activity many times in patients with chronic uveitis. On the other hand, one of a more devastating complication would be optic nerve atrophy. So the optic nerve may atrophy or get damaged over a period of time, either because of inflammatory processes itself, like would happen in leakage. It could be ischemic, as can be seen in patients with ARN or Behçet's disease, wherein the blood supply to the optic nerve itself is damaged and it leads to damage of the optic nerve fibers. Or it could be indirect effect. That means, for example, the patient develops glaucoma because of uveitis and then develops optic nerve damage. So that is an indirect problem. So this is the example of a patient who was on ATT and went on to develop an ethambutol-induced toxic optic neuropathy. So visual fields here were helpful in diagnosing the condition because they show these typical secocentral defects you may see in these patients. And now, lastly, I would like to move over to the intraocular pressure troubles one may see in patients with chronic uveitis. So at one end, you have glaucoma, and at the other end, you would have something called as hypotony. So glaucoma, it is important, very important point here because it can develop in any form of uveitis. So here I have tried to list more common causes which may be associated with particular subcategories of uveitis. So it is important when you see these conditions to make a mental note that this patient is at risk of developing secondary glaucoma. So first key thing would be to understand the normal aqueous drainage, and I would encourage all the PGs to understand this very clearly, because if you understand the normal aqueous drainage pathway and how the normal aqueous humor is produced, there itself it becomes easier for you to understand the different mechanisms which are at play in patients with chronic uveitis. So majority of the times, secondary glaucoma in uveitic patients is open angle. So when the angle is still open, but there could be changes happening inside the trabecular meshwork. Either there is a mechanical blockage because of an influx of inflammatory cells, or it could be inflammation of the trabecular meshwork itself. There could be damage to the trabecular meshwork, and even steroids, topical steroids, oral steroids can lead to a lot of resistance to outflow, resulting in open angle glaucoma. And at the other end, you have closed angle glaucoma, as we were discussing earlier when we spoke about iris bombay and peripheral anterior syndicate. Another important condition to keep in mind is acute VKH. So here there are no anterior syndicate, but there is forward rotation of the entire ciliary body, which results in a occlusion of the trabecular meshwork, again because of iris closing it up. And this is one condition where a UBM is diagnostic in giving you a clear diagnosis. So this is the example of another patient I have put up here to show how steroids themselves can result in glaucomatous cupping, and the visual field examination will show a complete, almost complete wipeout with only a central small tubular vision field remaining for this patient. So glaucoma management in uveitis is difficult. It is not at all easy. So medical management is something we usually start off with first. It is important to note that there are certain drug classes which you should avoid in patients with uveitis. So avoid the use of prostaglandin analogs. There's a higher risk of developing cystoid macular edema. Avoid the use of neotics like pilocarpine in inflamed eyes because it can lead to worsening of inflammation. So once you have exhausted your options as far as medical management is concerned, you have given maximal medical therapy or NMT as we call it, it is maybe time to move over to surgical management. Again, the course of surgical management is not easy because herein it is compounded by the chronic inflammation in the eye, leading to high chances of failure, blockage of your trab, blockage of your tube if you have done a Ahmed glaucoma valve or any sort of tube procedure. Ultimately, many a times these patients may require cyclodestructive procedures if it is already turned into an absolute eye. So the last thing I would like to discuss is hypotony. So hypotony, by definition, as you understand, is when the intraocular pressure goes down. So classically, we consider an intraocular pressure of less than 6 millimeters of mercury to be the cutoff point. But if the intraocular pressure continues to be less than 4, most of the studies say that that is going to have a very deleterious effect on vision. So hypotony is going to be a very, very common condition in patients who have chronic, uncontrolled, inadequately treated uveitis. There is a high risk in patients who have GIA-associated uveitis. There's a high risk of hypotony in patients with ankylosing spondylitis. So it is very important to keep in mind and look out for hypotony, especially in these patients. It is also important to keep in mind that if you are operating on an eye with hypotony and there is pre-op hypotony, it accelerates the chances of post-operative hypotony as well. So we do attempt to treat the hypotony initially with aggressive treatment, but many times these patients may end up requiring VR intervention and silicone oil insertion. So this is the example of a young patient, 22 years old, and you can see the cosmetic disfigurement she has come to us with. So this is the eye in close-up. You already see a lot of peripheral anterior synechiae. You see a membrane across the pupil, and she already has an axillary difference of more than 4 millimeters between the two eyes, which we pick up on ultrasonography. So again, this is a late-stage disease with hypotony and very, very difficult to manage. So the another important technique which one can rely on other than ultrasonography is UVM. So I have put up these two pictures here. So this first picture shows that the ciliary processes, which should be more in number, here are extremely reduced. So look at the ciliary processes, either they are blunted or reduced in number. So this is a sign of impending hypotony. At the same time, these patients may also, as we were discussing earlier, have cyclitic membranes resulting in traction, and over a period of time may develop hypotony. So ultimately, the last stage is phthisis bulbi, when the eye is small and atrophic, structures become unrecognizable. And on this ultrasonography, you can beautifully pick up this intraocular calcification or ossification, which has already started. And this is a sign of extremely poor or nil visual prognosis. So to conclude, I would like to leave these points with all our young listeners, that it is very important that you monitor patients with uveitis. Nothing beats a regular and good detailed slit lamp examination and a dilated fundus evaluation to look for majority of these complications. Go for regular intraocular pressure monitoring and documentation. You can rely on these multiple ancillary investigations as we have seen over the last few slides, and understand the role of each for each particular complication. Ultimately, if you have to manage, either you could have a medical management where you would use appropriate medical therapy in the form of either IOP lowering medication or mydriatic agents or aggressive steroids, or as we have heard in the last few talks, we can rely on the use of immunosuppressives or biologics in cases of chronic non-infectious uveitis. Ultimately, you may have to resort to surgical treatment in the form of either a cataract surgery or glaucoma surgery or a vitreoretinal procedure. But it is very important to keep in mind that do not operate on an inflamed eye. Achieve disease quiescence if you can. Give an aggressive perioperative anti-inflammatory therapy cover, and monitor closely for post-operative complications. So the only way to develop complications in uveitic eyes is by a correct identification and phenotyping of the disease, because that itself tells you about the possible course of the disease and the possible complications you may encounter in the future. It is important to, again, have prompt initiation of therapy. One of the most important things here is to ensure compliance via understanding. So it is important to spend those extra 10 or 15 minutes with a patient with uveitis. It is important for them to know the course of their disease and the various complications which can develop if the disease is untreated or if follow-ups are poor. So from your side, monitor frequently, have hawk eye vigilance, and go for early and appropriate intervention. And with all these things, it is really possible to prevent devastating complications in uveitic eyes. I would like to thank you all for your patient listening.
Thank you so much, Dr. Arshi ma'am, for your brilliant talk and wonderful clinical images and case examples. You covered comprehensively all the complications of uveitis. Thank you so much, ma'am.
Thank you, Aditya.
So I would like to ask a few questions to the panelists. Firstly, I'd like to ask Dr. Reema ma'am. So, ma'am, what would be your advice for timing of cataract surgery in patients with chronic uveitis? Let's say it's a fresh patient who you're seeing for the first time, comes with a quiet eye, who's been controlled for a long time and not on any medications, but has posterior synechia suggestive of chronic uveitis. What would be your approach to timing the surgery in these cases?
So if the eye is quiet and the patient has been quiet for quite some
Mm.
time, that's the right time to undergo cataract surgery, because you don't really have to wait for 3 months from the presentation till now. So from the records now, nowadays, the patients carry their records. So where they've been seen elsewhere. So if the eye is quiet, there is cataract, it's better to send the patient for cataract surgery, because that'll allow not only visual rehab but also allow a complete fundus examination. So baseline testing, I would recommend, even if it's a quiet eye, just try to do a fundus examination with an OCT. So if there's no cystoid macular edema, I think we are all good, and the patient can undergo cataract surgery.
Ma'am, any role of B scan in such cases to look for subclinical choroidal thickening or anything?
Not really. If the cataract is very dense, of course, we go for an ultrasound. But there we look for general posterior segment, like, there are no echoes in the vitreous and the posterior segment is fine. But choroidal thickening, you would have earlier clinical indicators, like the IOP would be low, and, there may be some corneal folds. So unless there are these findings, it's everything should be fine. So you have some clinical indicators where you would look for these things in an ultrasound, not in all the eyes.
Sure, ma'am. Thank you so much. And my next question, I would like to ask Dr. Basu. So when you have such a case which is controlled for a long time, yet there's a post-op relapse of uveitis, how would you tackle these cases?
Yeah, so thanks for the question and really comprehensive explanation of the complications of uveitis by Dr. Archie. So post-op recurrence, I think you treat it as any other recurrence, but it will primarily depend on which uveitis are we talking about. Are we talking about a juvenile idiopathic arthritis, AIE-associated uveitis in a child, or is it a VKH in an adult versus is it a B27 in an adult? Because all of these have different course of the disease, and that is what you need to judge, not only in terms of the etiology of the disease, but also specifically for the patient. How has that patient behaved over the last, over the period of observation? So, to give you an example, if it's a VKH patient who came to you with a complicated cataract, it means that the patient was controlled poorly even before he came to you. It's a chronic uveitis. So this is one case that you will probably keep on immunosuppression on a very long time. It's an adult, so very unlikely that there would be risk of amblyopia. So you keep on immunosuppression as long as you can, and only when you're absolutely stable that the disease is controlled, you go for cataract surgery. On the other hand, in a B27 patient, you know that this is probably a acute onset of uveitis, and it's unrelated so much to the cataract surgery. So you treat it only as as and when it happens, and not worry too much about a long-term immunosuppression for that patient. I hope that answered your question,
Yes, sir.
Aditya.
Yes, sir. Thank you so much, sir. And my next question I'd like to ask Dr. Bala. Sir, are there any predictive factors for ciliary body shutdown and cyclitic membranes in cases of chronic uveitis? Is there a way to know that the eye is going into hypotony? Can we predict it?
Yeah, it's such an important, interesting question with a lot of practical application. The most important thing is the duration of the disease. Normally, the cyclitic membrane or the hypotony happens with the disease of very long duration with a lot of untreated or mistreated scenarios. And obviously, we will get a clue from the low IOP. And as a clinician, we want to look at the asymmetry in the anterior chamber depth between the center and periphery. If you have a peripheral anterior synechia along with the seclusio pupillae, you expect the center to be very deep and periphery to be shallow. But you have an opposite picture, rather a ultra presentation.
So you're not audible.
To the cyclitic membrane. You need to order a UBM to rule out the cyclitic membrane when there is an asymmetry between the center and periphery of the anterior chamber. And why is it relevant? Because without suspecting cyclitic membrane, if you just do a cataract surgery and you will end up in a lot of post-op complication, which Dr. Arshi herself has dwelt in during her talk. And the identification of coexisting cyclitic membrane with cataract will make a huge difference, because in such scenarios, the cataract surgery can be approached in a much better way through the pars plana approach.
Thank you so much, sir. And my last question I'd like to ask Dr. Kalpana, ma'am. So we always have this debate. Now, we're not supposed to touch an eye that's acutely inflamed. So we delay cataract surgery and surgical procedures. But is there any such predicament when it comes to surgery in cases of inflammatory ERMs? Is there any such debate over there?
Inflammatory ERMs.
Yeah, like if you have a panuveitis or a vitritis, dense vitritis, you just go in and operate, or you wait, or
Usually we wait. Actually, Rima and Somavia would be better because they would be operating on this. I mean, from
would.
what I gather, you're trying to say if there is a lot of vitritis and then ERM, right?
Yes, ma'am.
Yeah, I think you can go ahead. Rima and Somavia will be able to answer that better because they are do that.
Indication for vitrectomy. You would not want to do a vitrectomy just because there is dense vitritis and ERM. If you are thinking of doing a diagnostic, then it works as a therapeutic also. But if you know that you are working upon the etiology and you can treat the patient medically without touching the eye at first stage, I think it's always good. If you know if you are aware of the diagnosis, but if you really want to go in for diagnostic purposes, you want to do some molecular test, PCR testing, or flow cytometry or cytology, then of course. But then I would advise, if you're going in for diagnostic vitrectomy because of vitritis, don't touch the ERM. You don't have to, because you would be um, you would be inducing the PVD, you would be touching the ERM, and then it's an inflamed eye. So in an inflamed eye, diagnostic vitrectomy up to the level of core vitrectomy, ERM should be tackled only once it's treated as a complication. The eye is quiescent, there are sequelae, and then you are operating the patient for an ERM removal.
So thumb rule would be we would want the eye to be quiet to touch the ERM.
Of course, ERM is never an emergency, right?
Yes,
So
ma'am.
ERM should never be done in an inflamed eye.
Thank you so much. That was just
Dr. Aditya, Dr.
Yes,
Aditya, I would like to add a point. Like in all this complication sequelae of uveitis, you will have a 2x2 table: active uveitis, inactive uveitis, active complication, inactive complication. Whether it is CNVM, glaucoma, cataract, everything. When you have active uveitis, focus more on controlling the inflammation first, and rather than the sequelae. That will be the rule of thumb. And the second rule of thumb, which I would like to add for the young students to remember, is when you have one complication, always search for the another complication. So the complications that are easily overlooked are the CNVMs and the cyclitic membrane, and the subtle clues could help. Like you alluded to the cyclitic membrane, and Dr. Rima's wonderful publication on how to suspect CNVM, subtle hemorrhage at the borders, or when there is vision is not explaining to the inflammatory indices. So these complications which are easily neglected should be really picked up by the clinician so that we give the best possible quality of care. Thank you.
I think
Thank
I
you
want
so
to
much.
comment here. So coming to active versus inactive surgery, one indication where you would not wait for inflammation to get quiet and you would go in even without diagnostic purposes is acute retinal necrosis with retinal detachment. So if you're seeing an RD in a patient of ARN, please don't wait for the ARN to get quieter because this RD is really bad. So one should go in the moment you see a retinal detachment.
So, ma'am.
Aditya, I would just like to add, ideally, we don't adjust immune suppression. I mean, we don't reduce immune modulation at least up to 6 months after surgery. I'm talking about cataract surgery.
Mhm.
So we generally, even if it is, we don't reduce the immunosuppression, even if it is HLA-B27 related, anything, ideally wait for at least 6 months before
So,
you think of reducing immunomodulation.
so patient who's already quiet on immunosuppression and we undergo surgery, we'll wait for 6 months to think
Yeah,
about tapering
ideally.
this
Yeah,
immunosuppression.
yeah.
Thank you so
It's
much, all
just a
the
practical tip. Yeah.
panelists, for your wonderful comments. I'd like to summarize our session. In short, I'll summarize all the 3 talks which we had. From Dr. JB sir's talk, we learned that PCR is a very useful modality for diagnosis of TB, toxo, viral uveitis with up to 70% yield and high specificity. We also learned that acute infection is the best time to take sample for PCR. And we learned that we must be wary of false positive and false negative PCR results. From Dr. Partho sir's talk, we learned that IMT agent works in various ways. Sir elucidated the inflammatory cascade and pointed out the different levels of action of different agents. We need to remember that unrecognized infection can be catastrophic in the setting of IMT, and we need to diagnose first and immunosuppress later. From Dr. Arshi ma'am's talk, we learned that about the wide range of complications from uveitis and the treatment of uveitis, and how we need to balance the treatment of uveitis with the treatment of its complications. I would like to now thank AIOS for organizing this GuruSangam platform, and thank you to our speakers for their excellent talks, and thank you to our esteemed panelists for their time and their valuable insights. Thank you so much.
Thank you. Thank you so much.
all.
Thank you very much.
Have a good
Bye.
Thank you.